If you've heard like a patient is saying he or she cannot walk downstairs because he gets double vision, what's up, folks? Welcome back to NeuroSketch with Dr. Ken. Welcome back to the discussion of the extraocular muscles, and today we are taking a closer look on the trochlear nerve, which is cranial nerve number 4. This is NeuroSketch, and so today you will understand why a patient with trochlear nerve can fails to walk downstairs. The patient with the ocular motor nerve with the trochlear nerve injury will fail to walk downstairs. So let's discuss about the trochlear nerve. So what do we say about the innervation of the extraocular muscles? We said the superior oblique muscle will be innervated by 4, the erectus by 6, and all other muscles by 3. What does it mean? It means the trochlear nerve, which is cranial nerve number 4, will innervate the superior oblique muscle. The superior oblique muscle. And what really is this superior oblique muscle? What is it? The superior oblique muscle. What are the range of movements that the superior oblique muscle will operate? What are the ranges of movement that superior oblique muscle will bring about? But before I mention anything about the movement, I once again insist that the primary position of the eye it is where it is because of the action of all muscles together. All the muscles together will act to bring the natural position of the eye. So the eye it is where it is because of the action. The primary gaze, at least. The natural resting gaze. The natural resting gaze. Like when you're naturally looking forward, that's primary gaze. And that primary gaze is being maintained by all the muscles. So when you are removing one muscle, all other muscles will do their parts, and we'll have a deficiency of movement that would be executed by this muscle that we have removed or that have got a weakness. Are we clear? So what is the superior oblique muscle? What are the movements that are made by the superior oblique muscle? I think you guys remember we say the superior oblique muscle will do intorsion, which is the medial rotation, medial rotation, but it will depress the eyeball, and that is the depression of the eyeball. But lastly, we will laterally rotate and laterally deviate the eye, and that is abduction. So intorsion, depression, and abduction. This is kind of repetition. So what do we get now when we are removing the action of the superior oblique muscle? So number one, if we remove the depression part of if we are removing, we are taking out, if you are eliminating a depressive effect of the superior oblique muscle, guys, the nerve that will supply the superior oblique muscle will be the trochlear nerve. And the trochlear nerve, when we get damage to the trochlear nerve, we are removing the action of the superior oblique muscle. What are the actions of the superior oblique muscle? Are here, the intorsion, depression, abduction. So I want to show you the consequence by eliminating each one of them. So number one, so if we are removing the depression, if we are removing the depressive part of the superior oblique muscle, the eye will elevate, and this elevation of the eye is what we call hypertropia. So we have two eyes over here. This is the left one, this is the right one. The left one has got no problem, the right one has got trouble with the superior oblique muscle. So number one, you see we have a horizontal line here, and all the eyes should be aligned, should be within the same line. But you see that if you take a closer look of this pupil is a little bit elevated. The pupil is above the line, so it is it is elevated a little bit. Why is it elevated? Because we have removed the depressive effect of the superior oblique muscle. And what is this elevation? How do we call this elevation? Is hypertropia. Guys, this is, I am taking you slowly and nicely for you to absorb all of it, okay? So So removing the depressive part of the superior oblique muscle, which is that into hypertropia, and hypertropia, it is elevation of eyeball with respect to the other. So the other one is perfectly like aligned, and it is on the same natural gaze, but this one is a little bit elevated. So that's number one. So what if we say we are removing the intonation part of this? The superior oblique muscle was the chief. It was the chief medial rotator. So the chief in total, we could say the chief rotator or the chief medial rotator. So if we are removing this intonation, the eye will laterally rotate. So along the anterior posterior line, and the eye will laterally rotate. So we have this extorsion, because you're removing the intonation. So all the other muscle that, for example, inferior oblique, will pull this eye to rotate it laterally, because it will remove the antagonist effect of this inferior or superior oblique muscle. Okay. So the eye, it's very difficult for you to observe the extorsion. It is very difficult for you. So the eye will be externally rotated. But what if also we remove the action of the abduction? So if we remove the abduction, the eye will be adducted. But I was telling you, like, it's very hard to observe the medial rotation. The external rotation. It's very hard for you to observe the external rotation, because the other time I told you we were observing the 12 o'clock position, but in actual eye you cannot see. There is no spot, there is no difference in the pupil. So the pupil is symmetrical, organized, so you cannot see like it has moved medial or lateral. So it's very difficult to see this extorsion and intorsion. But the adduction and abduction, for example, hypertropia, we can see hypertropia because you see this one has gone a little bit up, and then if you're removing the abduction, it will mean the eye will be adducted. So the eye will be adducted, and it will move a little bit to the medial side due to the action of all other muscles. So these are the consequences of removing the superior oblique muscle. So how will the patient complain? What will the patient tell you? The patient will tell you like he or she cannot walk downstairs. Why? Because he gets diplopia, he gets double vision. And what kind of double vision? It will be a vertical double vision or a vertical double vision. Why vertical double vision? Because this eye is perfect, this left eye is perfect, but the right one is a little bit elevated. So these two eyes are pointing into different directions. So this one is pointing upward, this one is pointing upwards, and this one is pointing centrally. So the patient will get diplopia. In that diplopia will be vertical diplopia. Okay, so what are the things that you can see, you as a doctor, you as a clinician? So you will see that the patient can be intentionally closing one eye, because then he tries to the biggest problem here is double vision. So he tries to correct the double vision. So if you close one eye, if you close the affected eye, of course you will see with one eye with no double vision, and that's one part of trying to solve the problem. But let me take you somewhere here. What other things that you can see from the patient apart from intentional closure of one eye? So a chin tuck. So this patient, we try to correct the diplopia by retracting back their chin. By doing so, they are by doing the chin tuck here, they are trying to correct the hypertropia, because the problem is this eye has gone upward. So the hypertropia means this eye has gone upward. So I want to bring this eye into level with the other eye. Okay, but I cannot bring this back because I've got no control of it. I've got no superior oblique muscle. So what I will do, I will try to make this eye, the other eye, the normal eye, to align with the damaged eye, with the superior rectus muscle, the superior oblique muscle damage. So what I will do, I will make a chin tuck, and I will try to make it back to correct the hypertropia. So I will depress. So I will move the head a little bit down to make the chin tuck, to try to bring this eye down. I mean, you try to it's hard to get this point, but I'm sure you will. What thing again you can see in the patient? What other thing that you can observe? Of course, they have the head, they tilt the head away from the affected eye. They tilt the head away from the affected eye. Why is that important? Why is it important to tilt the head away? Because remember, we have extortion. Because we have extortion, extortion means this eye has moved it laterally, as you can see. So if you see, follow the arrows, you see that the direction, this, I don't know, is it the direction or what, compass or something? Yes, compass. Follow this compass, you see that this one is perfectly like a cross, south, north and stuff, but this one is a little bit twisted. So it has a extortion, so it is extorted. And because it is extorted, I want now to tilt my head to this direction, so that this eye will have a normal orientation like this one. So this one will have a normal orientation by me tilting to the contralateral eye, to the contralateral side. So this one will go back to the natural position, and I will use the other muscle, the other eye, to do the movement. I know it's confusing. I know the trochlear nerve pass can sound intimidating, but of course I'm here to make it easy for you. Okay, so I have external rotation. So I have external rotation of this eye, the affected eye, the right eye. I have external rotation. Okay, so what I'm doing, I am trying to move my head to the normal eye, so that this eye will come with the movement of the head. So it will be brought back by the movement of the head, and by tilting this way, I will assume the natural position of this eye. But this one will be distorted because it is already moved with the movements of the head. But this one, because we have the superior oblique muscle, which is normal, it can make movement now. So this one, I brought it back to the natural position by the by tilting the head. Remember the oculocephalic movements, that's a different discussion somewhere else, but I will have brought it to the natural position, and then have trouble with this one, with this left eye, which is normal, so it can go back, you can make movement by the normal by the normal superior oblique of the left eye. Have I made myself clear? One last explanation. I have extorsion. The eye has rotated laterally, okay? And I've got no control to bring it back because the superior oblique is gone, okay? The superior oblique is gone. So what I can do, I can try to move my head to the other side so as to kind of, moving it to the natural position. While I'm doing so, I will treat to the other side, and then I will use, because this one has got no damage to the superior oblique, so I will use the movement of this one to look. So this one has brought it back, and then I will. So you can see from this picture here. So from this picture you can see this one is now, it has got into the normal position. So now it has got the natural position, but making this natural position with the head, this one will not be in the primary position. Okay, will not be in the primary position. So it has moved so as to compensate the movement of the head, and that's what we call the oculocephalic movement. Maybe we'll understand more by learning oculocephalic, and that's a different discussion. So by doing so, we have corrected extorsion and adduction at the same time. So chin tuck and head tilt to the contralateral side will correct these two. So we have got no trouble. We had no trouble with it. So and the vertical the vertical diplopia, of course we have already corrected, but this is another point I'm emphasizing. We have not perfectly corrected, but we have tried to cheat. We have tried to little bit cheat, so as to compensate the defect that is formed by having the trochlear nerve damaged. Okay, but we can so and then now the vertical diplopia, they will tell you the vertical diplopia is worse when this patient looks to the toward the nose. okay, and down. Why? Because because when you're trying to move to look towards the nose, you are aligning the optical axis with the superior oblique muscle. So the superior oblique muscle, remember, it comes from the trochlear and then it goes back, and so it will align with the eye. And then if it aligns with the eye, the superior oblique muscle will be the only muscle that will depress the eye and medially rotate. So it gives you the vertical diplopia. And the vertical diplopia is more it is more prominent when the patient looks medially and laterally, and looking towards the nose, So that is it about the trochlear nerve. I know trochlear nerve is very difficult to understand sometimes. It is so intimidating, but it should be easy for you. So don't forget to follow the last part, which is abducens nerve, the abducens nerve pass. So until next time, stay curious and see.